Hi everybody, I'm Dr Debbie Wake. For those of you who haven't met me before, I'm a NHS diabetes consultant based in Edinburgh. I'm an academic with the University of Edinburgh and I'm CEO and clinical lead of MyWay Digital Health. So thanks for joining us tonight. We're now at the end of our second day of the Understanding Type 1 online course. I hope that you've enjoyed being part of the course and enjoyed viewing the content today. For those of you who maybe haven't quite yet had time to look at it or go through it all, we are keeping the course open until Friday at 5 p.m. So you've still got a chance to go back in, look at any bits that you've missed or that you want to revise, or encourage other people even to have a look at the content online. So at 5 o'clock on Friday, it will be gone, but up until then, please feel free to dip back in. So as a reminder for anybody who isn't yet on the platform, it's understandingtype1.mydiabetes.com is the address for the online course, and it's been running, as I say, yesterday and today, and will be open till Friday at 5 p.m. So the way the Q&A is going to work for anybody who didn't join us yesterday is that this is your opportunity to send in questions to me and the team behind the scenes, who I'll tell you a bit about in a minute. And the way to do that is to either just add your comments under the video in Facebook, where the comment section is, put your questions in there and we'll pick them up and try to answer them. The other way to do it is, if you're using Twitter, is if you put a question in and also put the hashtag understandingtype1 alongside your question, then again we will pick up the questions on Twitter. So that's the two ways to get your questions in. So please start them coming in. The way we're going to work over the course of the hour is that we'll do a 10-minute Q&A. We'll then go offline for 5 minutes just to have a look at the questions that have come in, and then we'll come back on again, and we'll repeat that 4 times throughout the hour. So there will be short periods where we'll disappear to huddle to have a look at your questions. And as mentioned, there is a team behind this, and the rest of the team are there in the background supporting through answering the questions online. We've also got a WhatsApp group so we can all talk to each other, and they'll be helping. And the team are, first of all, Alison Campbell, who has been supporting and coordinating the whole project over the last couple of days. So thanks very much, Alison, for your time. And Kirsten Cumming, who has done a lot of the prior work up to this point. David Garrell, who is our partnership director and also has type 1 diabetes himself. We've got Alex Bickerton, who's a consultant diabetologist based down in Somerset. We've got Lynn Wilson, who's a diabetes specialist nurse based in Lanark. We've got Salma Meher, who is a dietitian based in northwest London, and Salma has a specialist interest in Black and ethnic minority community work with diabetes. So again, any questions particularly around that, Salma is your person. She's also been involved in developing the Carbs and Cals World Food Book. So some of you will be familiar with Carbs and Cals, which is a great resource as an app and a book to help you work out your carbohydrate content of food. Salma's helped develop a version that also covers other world foods for people from, for example, South Asian or Middle East backgrounds or African backgrounds and so on. So that's fantastic, and I'm sure she can tell you more about that if you want to know more, just ask. We've also got Magnus, who's here supporting from the technical point of view, and we've got Dr. Nader Lessam, who is a consultant diabetologist all the way out in Abu Dhabi at the Imperial College Diabetes Centre. So you've got a truly international group of experts supporting behind the scenes. So please do get your questions in and we'll be happy to answer them. Just picking up a couple of the questions from earlier on the course, just really to ask your comments on this. One of the questions we had was around snacks. So somebody who said, I've got type 1 diabetes, I'd like to have some snacks that aren't going to affect my blood sugar levels. I eat a lot of raw vegetables, celery, carrot sticks and nuts. Has anybody else got any good suggestions? And I thought you, as a diabetes community out there, might have some great suggestions just to share ideas around other sorts of snacks, low carb snacks that are good, that won't have too much impact on blood sugar levels. So I'll put that one out there. Just another thing I wanted to mention is that the course today and yesterday was really very much a taster course. So it was to try to just give you a flavour for some of the different topics that are important when managing type 1 diabetes. And I know a lot of people doing the course have diabetes themselves, but there's also a lot of carers and family members and also healthcare professionals. Regardless of that, if there's any bit of the course that you want more information on, it's likely that we will be able to deliver that through a follow-up course. So we already have individual structured education courses about carbohydrate counting as a course in itself, 2 courses covering insulin pumps, and other courses which go into a lot more detail in some of the topics that we've touched on today, things like living with diabetes, driving with diabetes, exercise, and so on. So if you want to know more, I would suggest that you go to one of the either the National NHS England site, which we manage, which is called mytype1diabetes.nhs.uk, and that's available to anyone in NHS England with diabetes. They can then register through that platform and will be able to access the 5 structured education courses that I talked about. There's also a lot of unstructured content on that site as well, including about 100 resources in other languages, which might be useful. If you live in one of the regions, and again, I'll put all this information into the Facebook comment section, but if you live in one of the other regions in NHS England, Manchester, Somerset, North West London, North East London, Lancashire, South Cumbria, Greater Manchester, Cheshire and Merseyside, then you have your own regional platform. You can register, access any of the courses, but you can also access your electronic health record online. So if you register with those services, what we do is we pull through the data with your consent from things like GP practice systems, make that data visible to you, and then we can provide a very personalised and automated service back to you to give you advice around your diabetes. You can also link in your blood glucose meter, and we also link up to things like Fitbits and so on. And in Scotland, we have the My Diabetes My Way platform, which has been around for many years and again supports people with all types of diabetes and has the same service offering in terms of linking your data up and accessing educational information and further e-learning courses. So that's your kind of follow-up for anything that you want more of. Just picking up on a couple of comments from the course today and questions that have come in. So the topics that we covered today were around complications of diabetes. And that was covering things like heart disease, foot disease, kidney disease, eye problems, and also diabetes and sex. And then we had a section on living with type 1 diabetes, so healthy eating, physical activity, alcohol, smoking, mental well-being, coping with illness, travel and driving. So these are the topics that we'll mainly touch on today, but if there's anything else that you want to discuss from earlier in the course, also very happy to look at that. So a couple of the things that came up today, so thinking about the diabetes and sex bit, we actually had a couple of people asking about options. So we talked a little bit about men and the fact that erectile dysfunction is a bit more common in diabetes, and it was interesting to see some people asking about Viagra, saying that, you know, they're not a bit worried about using it. Is it really safe? Generally, the advice is that we know that about 50% of men over the age of 50 with diabetes do have some erectile problems, so it's incredibly common. So we encourage people to go and speak to their healthcare professionals about that. It's also important to get assessed because there may be other reasons for that. We'll assume it's due to the diabetes, but things like low testosterone levels, which again can be easily supplemented, may be part of the reason. So it's good to get a check over, and it may be that your doctor might want to do some additional blood tests. In terms of Viagra, it is probably one of the best options we've got, and it works incredibly well in most people. The only people that we'd say not to use it is people with sort of serious heart conditions or people who are using nitrates, which are a specific type of medication for angina. So things like the sort of red spray that people use under their tongue, but it's more the sort of longer acting nitrate pills. So again, your healthcare professional will be able to advise you, and if you're using any of these drugs, it's not recommended. Otherwise, it's generally pretty safe and well tolerated, and actually does get some great results. If that doesn't work though, I'd suggest that there are other options, and usually you could access those through specialist clinics. So it would be up to your GP or your diabetes team to refer you into a specialist clinic, and they would be able to talk you through what some of the other options are. So the other thing that was asked a little bit about in the similar context was about the menopause. So how does the menopause affect diabetes? It definitely does, or certainly for some people it does. So there's no doubt that hormone levels, female hormone levels, can have quite a big impact on blood sugar control, and it's different for different people, so it's very hard to predict what that response is going to be. But generally during the menopause, women tend to become a little bit more insulin resistant, a little bit more susceptible to putting on weight, particularly around the tummy area, which is typically the sort of male distribution area for fat. And because of that, that can come with it some insulin resistance. So it can sometimes mean insulin requirements go up, but that, as I say, that does vary between people. and it can also mean that sort of weight loss can be a little bit sort of trickier over that time. Women as well, during monthly period cycles as well, often find fluctuations in their insulin requirements over that time. And it is just a little bit of trial and error, but a good tip is to keep a diary and just look at your insulin requirements and your blood glucose levels over the course of a month. You'll soon start to spot trends, and then you can hopefully start to predict that for the future and start to in advance, start to look at what you might want to do to adjust your insulin proactively. So that was the main things I was going to just say by way of introduction. We're going to just go offline for a few minutes, have a look at what questions have come in, and I'll be back with you again in 5 minutes' time. So please submit your questions either on the comments feed below the video or through Twitter on #understandingtype1, and we'll be back with you soon. Thanks. understanding type 1, just put that alongside your question and we'll pick up the questions. So just to pick up on a few other things for now, some of the questions interesting question came in about low carb for people with type 1 diabetes. So this is a slightly controversial area in that for people with type 2 diabetes, we're generally recommending one of the options for improving diabetes control or possibly even putting type 2 diabetes into remission is to consider a low carb diet. So by cutting the carbs out of the diet, that can help with weight loss, and it can also help with reducing glucose levels in the blood and reduce insulin requirements for people with type 2 diabetes. So that's fairly kind of well understood and is now one of the options that is being used for weight management and diabetes remission for type 2 diabetes. But what about type 1 diabetes? So we've had some experience with people who have on the course who've talked about they're using low carb options. And as well in my own practice, I've certainly come across some people with type 1 diabetes who are significantly cutting the amount of carb in the diet out. So by carbohydrate, we're generally not just talking about the refined carbohydrate like the sweet and sugary things, but also things like bread, pasta, rice, potatoes, any of the more sort of starchy carbohydrates as well. And getting that down to, generally when you're talking about low carbohydrate diets, you're talking about less than 130 grams of carbohydrate in a day, and sometimes even lower levels than that if you're talking about very low carb diets. The feedback, I think, from people, it's not a diet we would generally advocate for people with type 1 diabetes. We generally say to people, adjust your insulin according to your carb intake, but don't restrict your carb. So you can eat what you want, essentially, from a carbohydrate point of view. Obviously, with the caveat that everyone should be trying to follow a healthy diet, but just make sure you're taking the right amount of insulin in for the carbohydrate you're taking in. But there's no doubt that some people do find that it's easier to control their blood sugar levels if they're not eating as much carb. And you can see why that would make sense, that if, as you eat carb, then, if you've not quite estimated your insulin dose right, you might get spikes in glucose levels. If you're putting less carb into the system to start with, then it's probably going to be easier to control and your glucose levels are less likely to fluctuate. So although it's not a dietary approach we necessarily would advocate or promote, I think if people are finding reducing carbohydrate in their diet and therefore reducing their insulin requirements is working for them, and there's less variation in glucose levels, and you're able to monitor that carefully and make sure that you're adjusting your insulin appropriately to the amount of carb you're taking in, then fine. And I certainly know a few people who've found it's really made an impact, particularly on those variations in blood sugar levels, so they're not getting as many spikes and lows in blood sugar levels, they're getting a much flatter profile. So I'll leave that out there to make your own decisions on that, but it was interesting to hear some of the commentary on that on the course today and some questions coming in about that. The other thing that I just wanted to touch on was about sick day rules and ketones. So we talked a little bit yesterday about this, and it's just to pick it up, is when to monitor your ketone levels and what to do in terms of sick day rules. So everyone with type 1 diabetes should have some ability to monitor their ketones at home. So usually we will issue people with a meter that measures not just blood glucose but ketones, and that is using the same meter, but usually it's a different box of strips that you'll get for ketones. These do tend to expire a bit quicker than the glucose strips, so always make sure that you've got some ketone strips that are in date. Generally, we wouldn't recommend that people need to monitor ketones on a sort of daily or weekly basis. It's only really when there's potential risk of ketones increasing. So if you're getting high blood sugar levels, let's say above about a 14 on 2 occasions, then we would generally recommend check a ketone level just to make sure it's okay and that you're not going into ketoacidosis. Likewise, if you're unwell for any other reason, so if you've got some sort of bug, and at this time of year I think more susceptible to bugs, viruses and infections, although with the current restrictions and social distancing perhaps slightly less so this year. But if you do develop any sort of infection, bug, high fever, gastric upset, anything that might be upsetting your insulin requirements, we would recommend you do a bit more ketone monitoring. And if your ketone levels are starting to rise, that you respond to that. And respond to that in 2 ways: by increasing your fluid intake, but also by increasing your insulin if your blood sugar levels are starting to increase and your ketones are starting to increase. So your home ketone monitor should give you a reading. And if that reading is less than 1.5, that's generally okay. If it's between 1.5 and 3, then you definitely need to be doing something about that. You need to be thinking about adjusting your insulin, taking in more fluids, and getting some input from your healthcare team to make sure you're doing that safely and effectively. But we've given a flowchart in the course that allows you to do that. It suggests what the increase in your insulin dose should be. You should be monitoring blood sugar levels very regularly. If the blood sugar is still raised, then you need to be increasing your insulin again. So it's about taking frequent additional corrective doses of insulin to bring down the insulin and bring down the ketone levels, and also making sure plenty fluid so that you're not dehydrated. If you ever are in a situation where your ketone levels are above 3, we would suggest that you seek emergency help, because you are going into the diabetic ketoacidosis at that stage. That can be very dangerous. It can come on very quickly, and we would recommend you get yourself into emergency services. That means if it's out of hours, then that might mean phoning 999 or getting driven into the A&E department locally. During working hours, if your ketone levels are less than 3, between that 1.5 and 3, we would suggest you probably communicate with your diabetes team, assuming that you've got some sort of emergency helpline that you can speak to them, and they will be able to talk you through what to do. So I just wanted to clarify around ketones, because I think people were asking, when do I check ketones, how often do I check it? But some good feedback from the course today that people found the information useful, and it helped clarify a lot of that around ketones. The final bit I was going to just touch on today, in this bit before we close again to look at the questions, is around mental health. So again, we had a section today on mental health, and it was really great to get people's feedback on that, and a lot of people sharing stories about their experience of being diagnosed with type 1 diabetes, and that being an incredibly stressful time. I think some people on the course have only been diagnosed within the last few months, which been diagnosed during COVID and lockdown and all the restrictions must be incredibly difficult. So it was just really to thank people for sharing their experiences of that, and seeing how important it is to have friends and family around you, to have a good healthcare team around you who can support you. And I would encourage you to get your friends, family and other people to find out a bit more about type 1 diabetes. So we've had a lot of people doing the course who are carers, family members, who've said this is just great because I feel I can support my person with type 1 diabetes much better. So I would encourage you to involve them in what you do, make sure they understand, get them to help you through those low moments. Remember, people with diabetes are at higher risk of mental health problems by about 2 to 4-fold. So, if you are feeling low, then, do seek help. There is help out there for you, and people who can support you. And just one final question we might be able to squeeze in. Has come through. It says, my dad, who is type 1 like me, is always worried about having low blood sugar, as this seems to have stuck in his head that this is bad. It's unfortunately to the point that he'll let himself run very high, higher than he needs to, and thinks that he's running low when his blood sugar is about 5. It is very common. So you're definitely not alone. I see a lot of people in my clinic who are the same, who have a real fear of hypoglycemia. And that's partly maybe because they've just been warned about it at the start, and maybe for some reason have been that has given a lot of anxiety, or it may be because they've had a very bad experience with a hypo at the start of having in their diabetes journey, and that has just really scared them. So there's lots of reasons for that. We often try and work through that with people as to why they have that fear of hypoglycemia. So understanding what it is that's triggered that, or what they're worried about, or have they genuinely had an episode where they've been out of control, they've maybe had to get bystander support or help to treat their hypoglycemia. And I think once you understand that, you can start to unpick some of the rationale around that. I would say for most of our people who have well-controlled type 1 diabetes, they will get the occasional hypo. And I think that's just part and parcel of the tools that we have at the moment to treat type 1 diabetes. They are not perfect, and people have to work really hard to monitor the sugar levels and take insulin effectively in corrective doses. So if you want to run your blood sugar levels in that kind of good range where you're achieving an average glucose of, we say usually between about 4 and 7 before meals, maybe slightly higher, up to 8 at other times. But if you want to try and keep yourself in that tight band, then you the chance are you are going to have the occasional hypo. But most people have very good warning symptoms. They're able to pick it up early, they're able to treat it, and it just becomes part of having type 1 diabetes. If you do ever get into a situation where you stop getting warning symptoms, and that's often if you're having lots of hypos, then we would say wind back on your blood sugar control a little bit so that those warning symptoms can start to come back again. So it is a fine balance. In terms of people not feeling low at 5, what tends to happen is people get a thermostat reset point. So if you're somebody who always runs your blood sugars, let's say between 7 and 10, then actually by the time your blood sugars drop to 5, you will feel like you're having a hypo because your body is so used to having high blood sugar levels. And what you need to do is just gradually reduce and improve your targets over time, and eventually your body will reset so that you start to get hypoglycemic symptoms at about a 4. So that's just about a sort of gradual reset of the body and what it's kind of used to feeling. So yeah, people who say they feel low at 4, 5, 6, 7, they probably do. That's a genuine feeling that they're getting, and you just need to work with people to gradually improve their blood sugar targets so that they start to feel normal when their blood sugar levels are at 5 and 6, and hyposymptoms will come in usually just when people are dropping below 4. So will we do one more just now? We'll do another quick one just now, sorry, and then we'll... So somebody says, COVID issues, no retinal screening appointment. Past 5 years, it's been in early November, guessing there's been a delay. There's quite a lot of discussion on the course today about retinal screening appointments. Yes, unfortunately, there is a backlog. So most people we recommend to get their eye screening done once a year. Obviously with COVID that's stopped, there's now a huge backlog. So what the retinal screening programme certainly in Scotland is doing, and I expect it's the same elsewhere, is they're now playing catch up, and what they're doing is prioritising those at highest risk. So you will, if you've been on their register in the past, they will get in touch with you. But yes, there will almost certainly be a delay this year. Don't worry about that. They'll get in touch with you. Obviously, if you do develop any eye symptoms, particularly any sudden onset of visual change, get in touch with your healthcare team. They will see you sooner. If you've not got any eye problems, they'll get in touch with you in due course. An interesting bit of research that's just come out and will be potentially implemented in Scotland is research that shows that if you're low risk, if your retinal screening has generally been okay and you're at low risk of diabetes complications, there is some new guidance coming out that may suggest you only need an eye screen done every 2 years. So I think we will be moving to that quite soon. So actually, if you're somebody who's low risk and it's over a year since your appointment, actually that may become the norm anyway in the future, and we'll only be seeing low risk people every 2 years, because the suggestion is actually the chance of any significant deterioration occurring in a 2-year period is pretty low. So hopefully that's given some reassurance about the eye screening stuff, but if you've got any concerns, obviously contact your healthcare team. Otherwise, we will stop for a minute just to go away and pick up any other questions. Please bring your questions in. If you've got any particular questions around COVID as well, very happy to think about those and answer those. Obviously, this is a stressful time for people. We know that it's impacting people's mental health, but we also know that people with diabetes, there's sometimes often been a bit of confusion around what you should be doing around social distancing. So again, very happy to answer any COVID specific questions as well if I can. So we'll break for a couple of minutes and we'll be back again with you soon. Thanks. Hi everybody, thanks again for being part of this evening's Q&A. Get your questions in. There's been a few things coming in on Facebook, but please keep posting your comments under the video on Facebook and we'll pick those up. And also on Twitter, #UnderstandingType1, just put that alongside your Twitter comment and we'll pick it up. Hi to everyone on Facebook, YouTube and Twitter. We're live streaming across all the different platforms, so hi to everyone out there and thanks for being part of this. We'll just, as a reminder, we'll point you back. We've had some interesting stuff coming through on the Facebook comments. There's also some good information there about links through to the courses and the platforms if you want any more information or more educational content. Those are the places to go to. So just going to go straight in to answer some of your questions. So first one is, I'm one of those people who've had high bloods for years. I don't sleep very well in case I had a hypo. And it's only now that I've got a new team that are great and very supportive. Well, first of all, glad that you've got a good team around you, so that's great and hopefully that will make a big difference. I think in terms of sleep, blood sugar levels definitely can affect sleep, both if you've got high blood sugar levels, that can affect brain function. Obviously having hypos overnight can affect your sleep. Getting up at night to pass urine if your blood sugar levels are a bit high can affect sleep. What I would say is one of the great breakthroughs has been the Libre flash glucose monitoring system, particularly because it can monitor your blood sugar levels pretty much every 5 minutes, including overnight. So it can be a real game changer to allow you to kind of keep track of blood sugar levels over those periods of time, reflect on the blood sugar trends, and with your healthcare team, hopefully they'll be able to work out with you a better insulin regime that manages to keep your blood sugars down during the day so we can start to bring down those high blood sugar levels and reduce your long-term risk of complications, but actually not have your risk, not increase your risk of hypoglycemia. So it is a fine balance, but usually we can achieve an insulin regime that works well for people. If you're particularly susceptible to hypos overnight, it may be that you're just having too much insulin in the evening time, or that your basal, your background insulin is too high, and that's dragging down these blood sugar levels overnight. So there's lots of reasons for that, and glad you've got a healthcare team working with you and hopefully they can work through these issues. But I would definitely explore the option of getting an Abbott Libre system from them as a bit of tech that will really help you sort of work out what your patterns are during the day and night, and you can use that to work on your insulin regime. So thanks for that. Somebody asked, will we have access to the individual questions and comments? So as you've been going through the course, there has been a commentary at the bottom where people have been able to post their comments and get questions, get answers back to those. The course will stay live until 5 p.m. on Friday. So you can go back into it as many times as you like between now and Friday at 5 p.m. After that, I'm afraid it goes. We're not allowed to hang on to the data, as part of the restrictions around that. So if there's anything there that was useful, I would suggest you copy and paste it into some other document, including any questions you've had to your specific, any answers you've had to your specific questions. So you've got till then to get in and do that. Somebody else asked about something to do with their optician, and I think the question probably related to something we discussed in the last session around retinal screening. So at the moment, the National Retinal Screening Programme is behind in terms of doing the retinal screening updates, so you will probably be delayed in getting your appointment. For most people who are at low risk or who haven't had significant eye problems in the past, that's probably not an issue. It's unlikely that you will have developed any significant new eye pathology over that time. Obviously, if you have new symptoms, do go to your healthcare professionals and tell them about that. Some people asked, is it okay to get that done at the optician? I think it's fine to get these tests also done at the optician. Some of the opticians can do a photograph at the back of the eye and give you some reassurance around that, but it shouldn't replace the screening that you get done through the National Screening Programme. So what happens when you get your official photograph done is it goes into the national system, it goes through an automated scanning and screening, and then may or may not be picked up separately by a healthcare professional to review that, and it gets formally graded for diabetic retinopathy. And that feeds back into your recall system, whether you need any specialist input, and it goes into your record and contributes to other sort of scheduling. So if you go to the optician and get it done, they might be able to give you some reassurances, but it won't go through that whole thorough quality management process, and it won't become part of your diabetes record, which is important for us influencing when your appointments might be and so on. So I'd say that's fine, but also make sure you get your proper screening appointment done for your retinal screening when that becomes available. So hopefully that's answered some of the questions around eyes. Graham had a question with the great news of a COVID vaccine. Are you aware of any research breakthroughs, no matter how small, in relation to diabetes? So I'm not sure if your question, Graham, is specifically related to the COVID vaccine, so I'll maybe say something on that, and then I'll maybe just talk a little bit more generally about some of the research that's come out in relation to COVID and diabetes. So in relation to the vaccine itself, I'm not aware that there's going to be any issues that I've heard of in relation to people with diabetes having the vaccine, and in fact they will be one of the prioritised groups because obviously they're at higher risk of potential complications with COVID. So I don't know, there is a kind of tier system in terms of what they're currently proposing for the priorities for the vaccine, and diabetes is certainly up there near the top of the list as a sort of long-term condition that puts people at risk. In the same way as we encourage people to get the flu vaccine every year if you've got diabetes, we'd be encouraging people to get the COVID vaccine. And again, there's nothing I've heard that would suggest that that's going to cause any particular problems for people with diabetes. People will be aware that you, if you have diabetes, there is a slightly higher risk of poorer outcomes from COVID, which is why we've, we haven't been telling people to completely socially isolate if they have diabetes, but to take good precautions around shielding. Some of these figures have been slightly distorted, probably because people with diabetes are also at higher risk of some other long-term conditions. So we see a clustering, particularly in people with type 2 diabetes who are older. There might also be a clustering around things like heart problems, lung problems and other things. So for younger people with type 1 diabetes who are well controlled, actually the risk of poor outcomes with COVID aren't that much more than the general population. I think the biggest risk factor for COVID is age, regardless of whether you have diabetes or not. And it's also having some of these other sort of comorbidities with that as well. We also know that people who are carrying more weight are at higher risk of poorer outcomes with COVID. So hopefully that's given some reassurances, but there's been nothing particular in relation to the COVID vaccine that I would be worried about. I hope that answers your question, but anything else about COVID and diabetes I will try and answer if you want to get any follow-up questions in. There was a question about what is the best go-to no-carb snack for when you have the munchies. Currently snacking on lots of calories, carrot, celeries and nuts. Any recommendations? So Salma, thank you for responding to this. So Salma is our expert diabetes dietitian and says if you're looking for no carb snacks, so generally snacks without carbs that aren't going to have an impact on blood sugar levels, nuts such as peanuts, seeds, vegetable sticks, olives, tomatoes, cheese or even berries all have less than 10 grams of carb. So some of those things aren't completely carb-free, but they're low carb. So hopefully that's given a few options as to things that you might want to try. Other thing I was just going to pick up on a little bit was around physical activity. So we talked a little bit about this yesterday, but we had quite a lot of information on the course today about insulin adjustment and activity. Activity is difficult and it is a bit of trial and error, and thanks for those who kind of shared their examples of what they do. So people who are on insulin pumps talked about, reducing their background basal rates to 70 or 80% when they're doing certain types of exercise and then putting it back up, which is fine if you're on a pump, and in some ways pumps are easier to manage exercise with. One of the things that we talked about on the course is about having insulin on board. So if you are doing quite strenuous physical activity, it's very important that you have insulin on board. So a lot of people think exercise can potentially cause low blood sugars, and that is true. You will use more energy during exercise and your blood sugar level may drop, but you do need insulin to be in your system while you're exercising, or that glucose will not get into the muscles. There's no way of dispersing the glucose from the bloodstream into the muscles. So important to have insulin on board, but also important to make sure that any rapid acting insulin, for example, that you're taking prior to exercising is appropriate in terms of in taking into account the fact that your glucose requirements, your glucose burn may be higher. So hopefully that makes a bit of sense. Somebody gave a really good example in the course today of, when I go out for a walk before breakfast and I've not taken my insulin and I've not had my breakfast, my blood glucose levels rise, and I don't understand why that is, but it may well be it's because their background insulin is running out a bit. They don't have much insulin on board. Therefore, the blood glucose isn't being dispersed into the tissues effectively, so the blood glucose levels are actually rising a bit. Whereas if you exercise after you've eaten, when you've got insulin and food on board, actually you've got both of the components that you need for energy to be dispersed into the muscles. So the insulin's important for dispersing that. So hopefully that makes a bit of sense. We've given lots more information about exercise and diabetes. So if you've not looked at the course today, go and have a look at that, and you can work through some of the examples and hopefully work out what's going to work for you. Generally, the rule is if you're doing longer, sort of slower, sustained exercise over a period of time, blood sugar levels are likely to gradually drop over time, and you may need to take some carb on board or reduce your insulin requirements. If you're doing very high intensity, fast paced exercise like sprinting, because of the extra stress hormones in the system, you may actually get a slight rise in blood sugar levels. So the type of exercise you're doing, the intensity of it, and the length of exercise are all really important for figuring out what to do with your insulin and your glucose and carb requirements over that time. So hopefully that's been helpful for that. We'll maybe just have another short break and then come back to you with the final for a few minutes roundup. So any final burning questions, this is your time to get them in, either through the Facebook comments or through Twitter, #UnderstandingType1, and we'll be back with you again in a few minutes. Thanks. Hi there, we've just come back a bit sooner because we've only got a few minutes left till we finish at 6 o'clock. So I just wanted to get through a few final questions. So thanks everyone again for sticking with us through the hour. Thanks Sharon, who's asked a few questions, and I'll start by tackling some of them hopefully. So you've asked, is there a maximum amount of carbohydrate that the body can absorb or digest per hour? Now I'm going to bounce this one to Salma, who's our expert dietitian, because I don't off the top of my head know the answer to that. I don't know if anybody else does in terms of body physiology, but we'll see if we can get an answer to you on Facebook on that one. Your next question is there a maximum amount of carbohydrate that you should be aiming to eat less than per meal? If you've got type 1 diabetes, we generally say there is no restriction around your carbohydrate intake. That's quite old mantra when we used to say to people you have to restrict carbs. Nowadays it's very much about eating what you want to eat but matching it with insulin. So I would say there's no restriction. Obviously we would recommend people have a healthy diet generally. So I think sticking within the healthy diet rules, I would say no, just make sure you're matching it. And if you know what your insulin to carbohydrate ratio is, then you should be able to work out how much insulin you need to take to cover the carbohydrate in the meal. And obviously that's going to be more if it's a big carb meal, less if it's a low carb meal. We talked earlier about some people with type 1 diabetes experimenting with lower carb diets and finding it easier to control their blood sugar levels on that, but that's a personal choice really. So hopefully that's answered your question. You've also a question coming in saying, I've had type 1 diabetes for over 33 years. I've been on an insulin pump for 6 to 7 years. I have a sensor, presumably that's a Libre sensor for a while now, but my estimated HbA1c is showing 0.9% and then 0.8% less than my actual HbA1c. Could my low iron levels be a reason for this? Okay, so when you get an HbA1c blood test done at the clinic, there is a number of reasons why that may give a slightly false reading, and one of them is if you're anemic. So as you've rightly said, if you are anemic and your blood cells are turning over a bit quicker, then it may show a falsely low HbA1c. So I wouldn't expect that to explain why your actual HbA1c was higher. In fact, I would expect that to show a slightly lower HbA1c if that was influencing it. But for most people, a little bit of iron deficiency probably doesn't have much impact in HbA1c. It's usually when people have a sort of significant iron deficiency or have another problem where the red blood cells are turning over too quickly and are significantly anemic. So that's probably not the explanation. I think what we do know is that there is a difference between the way that we measure HbA1c in the clinic and what your Libre system does, which is basically looking at your time in range, your average blood glucose levels, and then basically doing a calculation to say roughly what does this mean in terms of HbA1c. So they are never going to be the same because the way that the two things are calculated is using a completely different standard. HbA1c in the clinic is looking at your red blood cells. Now your red blood cells roughly replace themselves every 3 months, and during that process the sugar will stick to the red blood cells. So really we're looking at how much sugar a red blood cell has picked up over a 12-month period. The Libre system, on the other hand, is actually measuring physical glucose in the blood on a day-by-day basis, and all it's doing is giving us the average of that. So the two things are measured in a different way. What's interesting with the Libre system is that we're now looking much more at time in range, and I think in the future we will stop even probably using HbA1c, quite a radical thing to say, but we will be using time in range on Libre and similar glucose monitoring systems as the way that we think about glucose, because we know that that's actually much more sensitive and accurate at predicting long-term complications. And what we're trying to do is keep people in a set range. So on your Libre you might have a 4 to 10 time in range, and what we want to get is the amount of time that you spend in that period as high as possible. So I think the way that we think about glucose control and the way that we measure it is going to change significantly as the technology changes. So hopefully that's answered your question, but I would never expect the two things to be exactly the same. And actually being within about 1% on the HbA1c isn't bad in terms of the two kind of roughly marrying up. Somebody else saying, has anyone else had problems with their Libre phone reading when it gets too cold? So this is from Anne. This has happened several times over the last few days. It's certainly been cold enough over the last few days. So I have heard this from some of my patients saying that that they can have some problems in the cold. I'd be really interested if Lynn or Salma are answering any of the questions on Facebook, perhaps put in anything that they've got, or Alex and Somerset, if you've got any experience with people reporting problems with sensors in the cold, then that would be really good to know. But certainly walking the hills of the Scottish Highlands in the middle of December is probably a good test of that. I'm not sure if there's any tips that people have got in terms of preventing that happening, whether covering up the sensor, keeping it warm or anything will help with that. Sharon's asking, I'm on Freestyle Libre sensors. Are there any different depths of sensors? As I wonder why some of my blood testing kit readings sometimes aren't corresponding with my sensor readings at all. So I think that's an interesting point, is that it's not, Libre is great at looking at trends. So if you want to see whether your blood sugar level is rising or falling, because it's doing those measurements every 5 minutes or so and giving you a kind of constant readout, that is fantastic for knowing what direction your glucose is going in. And also, is it falling rapidly or is it falling slowly? So you can start to predict where you're going to be in, you know, an hour's time or in the sort of future. So you can start to pick up early and adjust your insulin and adjust your food intake and so on to compensate. What it's not great at is giving you an exact reading of what your blood sugar level is at that point in time. So if you compare an individual Libre reading and you do a finger prick reading at that time, the likelihood is that there will be a difference. The Libre will always lag behind the glucose reading. So always trust a finger prick reading if you want to know exactly what your blood sugar level is at that time. And for example, if you feel hypo, but your Libre is saying you're not hypo, you probably are hypo, and check a finger prick reading and that will give you an accurate result. That's partly because what the Libre is doing is it's measuring interstitial glucose. It's not measuring sort of blood glucose. And there is always a lag between the glucose level in the blood penetrating through the interstitial fluid under the skin and actually sort of equilibrating, if you like, with the fluid there. So it will always lag behind. It doesn't quite have the same calibration that finger prick glucose readings are, but what it's brilliant at is showing you the rough trend of your glucose and whether you're heading high, heading low, and it allows you to kind of predict and adjust things. So hopefully that makes a bit of sense and helps you understand why the actual readings themselves may not correspond. Sue has asked a question, are people with type 1 diabetes more susceptible to cataracts? Are there any risks to people with type 1 diabetes with cataract surgery? Yes, people with diabetes generally are at higher risk of cataract. So we often talk about diabetic retinopathy as in problems at the back of the eye, but there are other eye problems like glaucoma and cataract, which people with diabetes are more susceptible to. Is there any particular risks with cataract surgery? Not really. I mean, I think if you have diabetes and your blood sugar levels are not well controlled, then for any surgical procedure, there is a risk that you won't heal as quickly and there is a higher risk of infection. So we'd always say to people, try to make sure in the run-up to any operation that your glucose control is really good. Obviously, during the time of the operation, the staff in the hospital will hopefully monitor that for you. And then after the operation, for the days and weeks even after the operation, whilst you're healing from that operation, make sure your glucose levels are really good. And that will make sure that things heal properly and that you're at less risk of infection. So hopefully that's helped with that. We've got just a minute or so left, so I just wanted to wind up by saying thanks very much for everyone who has joined the course. If you want to go back and look at the course, it will still be open until Friday at 5 p.m. And if you have any friends, family or anyone else who wants to do it, then there is still a small window of time where they can get in and do that course. So please share information about the course. Understandingtype1.mydiabetes.com is the link. So share that, share the information from the Facebook page here today, the information on Twitter, or send out an email. So let your friends and family know about it and share it with other people in your diabetes networks and communities so that they can take part in that. Also, please do use the other resources that are available to you. And again, in the Twitter feed, we've linked you through to the My Diabetes My Way platform in Scotland, the mytype1diabetes.nhs.uk platform in England, all the regional platforms. There's lots of information on the public websites that you don't even need to log in to access, but if you want to do any more of the structured courses, you will need to set up a new separate registration process to access that material. And also, if you're in one of the regional platforms of Scotland, you can access your electronic health record online, all your screening results, your medication information, and people find that really helpful for just keeping track of their diabetes. So I hope that's been useful. Really thanks for joining us today. Thanks for the feedback. I'm just reading comments from Sue and Anne saying, brilliant course, fascinating course. Thank you. Despite having diabetes for over 45 years, I've learned a lot. So that's really great to hear that, Sue. Thanks for your comments, and everyone else for the positive feedback. We had a few technical hitches on the course today where people were struggling to progress through the modules. Apologies for that. I think people managed to bypass that using the navigation. I think it's all fixed now, so if anybody wants to go back in and revisit any of that, please do. Any other feedback, any other questions, please do get in touch. Thanks for filling in our questionnaires at the start and end of the course. That will help us make the courses better for the future. And also, if you've given us permission, then we may get back in touch with you in the next few weeks just to get some feedback a few months on to say, you know, has this course helped you make any sustained changes to your diabetes? So otherwise, thanks for joining us tonight. Thanks for joining us on the course. Thanks for your support, and hopefully wishing you all the best really with your diabetes journey, but do get in touch if we can help. Many thanks.